Today, I'd like to cover what we call cell therapy promises and challenges. This is an extremely large and varied topic, and I hope that over the next few minutes of 40 minutes, I will be able to describe to you the landscape of cell therapy. It's a huge topic. I don't think I do justice to it, but it's a very exciting field. And today I'm very excited that I'm going to be sharing with you what this is all about. So I think the topic of today, I'll break it down into 5 main topics. First, a background of what cell therapy is all about, history of cell therapy, and of course, what is the current and future uses of cell therapy. With cell therapy, we cannot forget about CAR-T because CAR-T is the only one that's FDA approved therapy currently at the market. So definitely I'll be talking about that. And finally, everything has challenges, and what's the challenges faced, and how do we bring cell therapy to the public, and how do we do about that, and what problems that we face. So without further ado, let's jump straight into it. So what is cell therapy? In a nutshell, it is introducing new healthy cells into a patient's body in order to replace the disease or the missing ones. So this is what cell therapy is all about. And is it already going on? Yes, we have been using cell therapy for years now. Blood transfusions basically is what it is. We're giving red blood cells to patients who are missing red blood cells. And we've already been doing this for many, many years. And bone marrow transplant, this is also has been going on for years. And bone marrow transplant is taking patients' stem cells, which produces the red blood cells, white blood cells, and platelets, and giving it to patients who have lack of these cells. So we have established cell therapy, but over the last few years, things have taken a major leap forward, and we'll actually be talking about that later on. So human cells is amazing. We have 200 over kinds of cells in our body. We have nerve cells, muscle cells, skin cells, just to name a few of the cells in it. And all these cells, 200 over of these cells, are generated from a single cell, or what we call the fertilized egg. All right, so you can imagine that from a single cell itself, we can generate so many cells. And what does this cell? This is what we call a stem cell. A stem cell is a blank cell, so-called blank cell, or it's a precursor cell, and gives rise to multiple different skin types. So from one cell itself, it can differentiate into what we call skin, muscle, and nerve. And essentially, we can call the stem cell is a building block of human body. And so what are the properties of stem cells? They have 3 unique properties. They are capable of dividing and... Okay, I'm so sorry about that. My connection just dropped off suddenly. I'm now back. So sorry to the audience about this. Really don't know what happened to the internet connection. I hope that it's really stable right now. So I think apologies once again, and hopefully everything goes smoothly from now onwards. So back to stem cells. So we're talking about stem cells, and of course the earliest stem cells that we know about came from embryonic stem cells, because we know that this is the master cell that things come from. So of course we have the embryonic stem cells that actually come from a 7-day embryo. We call it embryonic stem cells. We have embryonic germ stem cells, which is a 6-week embryo. And of course we have the adult stem cells that we can actually get from it at the same time. And of course placenta stem cells as well. So you can see there are many avenues for us to actually get stem cells in patients. All right, so before I jump into it, I think it's always good to know about the history of cell therapy, or what it is. So perhaps it can be traced back to the 19th century. James Brundle, this is a guy who actually, obstetrician, who performed the first successful blood transfusion to a patient with postpartum hemorrhage. All right, so he actually is the one, and it was done in 1818. Actually, before that, have people been giving blood transfusion? Yes, actually, people have been in the 16th century been trying to give blood from lambs to people as well. Of course, you can imagine if you give blood from an animal to a human, the results can be quite disastrous. And of course, that didn't take off until James Brundle come about. And of course, there's also Charles Bourne-Sicquart, actually injected animal testicle extracts into attempt to stop the effects of aging. He tried, of course, that was not very successful as well. But these are the cell therapies that have already been going on in the 19th century, late 19th century. And of course, we're talking about just now about hematopoietic stem cell transplant. Don Thomas was a professor in Washington, and he was the first doctor that actually successfully gave stem cell therapy to patients. And of course, he won the Nobel Prize in 1990 because of this groundbreaking work. So once again, stem cell transplant, this is what it's all about in a nutshell. And this also applies to cell therapy that I'll be talking about later. You actually take the cells from a donor, you process the cell, you give chemotherapy to the patient, and then to wipe out all the leukemia cells or the cancer cells in the patient. And finally, you reinfuse the cells back to the patient to engraft into the bone marrow and to produce new cells as well. All right, so in the 1990s, this is where cell therapy and stem cell therapy really starts to take off. I'm sure all of you will remember the first embryonic stem cells was first found in the mice. And then finally, we think about cloning of Dolly the sheep, the first animal sheep clone. And then we went on to do isolated human embryonic stem cells and grew them in the lab. And then finally, Shinya Yamanaka actually was able to reprogram ordinary human adult cells to form induced pluripotent stem cells. And this is important because we're now able to move away from the embryonic stem cells and all the controversies of using unborn or embryonic stem cells for research. And then finally, in the 2000s and hence, this is when medical treatment or trials of medical treatment using embryonic stem cells was started in using for spine injury, blindness, and human trials started using immunotherapies stem cells as well. So you can see that the progress has been accelerating towards especially in the 21st century. So what's the current and future uses of stem cell therapy? There are many uses of it. I think it can be going into 4 main uses. By basic research, biotechnology, cell-based therapies, and of course, gene therapies. So what can stem cells be used in basic research? We can use these cells to identify or clarify complex events that happens in the human development because these cells can divide. So we know what controls it, how these cells divide, how the cancer cells grow, how they signaling in these stem cells. And we can finally find out what is the theory of cancer using stem cells. So this really helps and very useful for researchers doing basic research in understanding the origins of diseases or cancer in this aspect. What about biotechnology or drug discovery? We can imagine these stem cells, we can differentiate them into different cell types, and we can test drugs on these stem cells rather than testing them on animals and in humans, and we can screen numerous drugs using this. All right, and we can use cancer cell lines, and these have been used to screen for potential drugs, and we can use these different cell types to actually allow drug testing for different cells as well. So you can see this is one of the illustration treatment we can actually use and target treatment using the stem cells for it. At the same time, you can see that we can use stem cells for drug delivery. You can see here, the one actually is a tumor in the brain, and then by injecting neural stem cells, actually the chemo drug will localize and go towards the brain, and so we can localize drug therapy and give targeted therapy to the tumor itself. So I think this is where the interesting or exciting part as a clinician myself see the uses of stem cells. You can see there is a huge amount of potential targets or cure or supposed cure for all these diseases. You can see that wound healing, skin grafting, we already have been doing it. Osteoarthritis already has been many studies on it, but I'll be talking and bone marrow transplant, of course, which I already mentioned and is currently very established. But you can see there's a whole host of other potential diseases that stem cell therapy is being explored to treat. I cannot cover all of them in this overview, but I'll be touching on just some of them so that you can give the audience a flavor of what is to come. So, of course, in neurological disease, we have a thing called Parkinson's disease. As you know, Parkinson's disease is a movement disorder due to aging. It's due to a loss of midbrain dopaminergic neurons. So there's the neurons are not able to produce dopamine. And so what people have been done is they actually transplant tissues into the brains of patients. And then, of course, we have moved on to use mesenchymal stem cells to actually infuse into the brain as well. All right, so this is just a schematic to show you. Actually, you can use different kinds of pluripotent stem cells to to infuse into the patient. You can differentiate them. You can use different ways of getting all these stem cells, and these actually become transplanted into the brain and into the animals as well. And so far, animal studies have been doing it in animal studies as well. But in Japan, actually, you can see that this newspaper article published in 2018, there's a first of its kind clinical trial that used reprogrammed adult stem cells to treat Parkinson's, and this has been already been used, waiting the results of this study. What about spinal cord injury? You can imagine patients with spinal cord injuries, they're paraplegic or not able to walk and not able to move their arms. They are thinking of using stem cells to actually grow the axon, so-called, to connect the different, the neural connections itself. There is proof of recovered. Has it been proven? Well, not really in stringent clinical trials. However, they actually have done in Japan, actually 13 patients actually who suffer from recent bone injury, and they given stem cells isolated from their bone marrow, and it aided in regaining some of the lost sensations of mobility. So this shows that the proof of concept that in most probably there is something there and with something to be further explored. And actually, because of that, Japan in 2019 approved stem cell treatment for spinal cord injury. But because it's so preliminary, scientists are very worried there's insufficient evidence that it works. Other neurological conditions are also available, like multiple sclerosis, ALS, strokes. There are proof of concept. Numerous papers are being published, animal trials or phase 1 clinical trials. But these are all very, very early studies. And to show any promise at all. But these is exciting times, especially neurological conditions are very debilitating. And currently right now, our treatment for them is extremely limited. So another established one is eye diseases. I can see that this is a very busy slide, but this is just to show you that what current trials, phase 1 and phase 2 trials are being done in this arena. Most of it is in age-related macular degeneration, which is called degeneration of the retina, and it's been done in numerous countries. You can see in China, in Brazil, in the US. So many countries are exploring this as well. And so basically they use two sorts of forms. Like I said, they can take it from the embryo, or they can take it from the patient itself, use the skin, use a couple of enzymatic treatments to put it into a pluripotent cell and to re-implant these cells into the patient's eye. So it is still in infancy, but you can see that there's a lot of interest and there's a lot of trials coming up for it. And what happens in the end is that they actually use to just inject the cell straight into the eye, but that has been limited efficacy. So moving on forward right now is that they are transplanting sheets of cells, or sometimes you put a scaffolding and implant it into the eye itself, and to see whether this improves the uptake of these cells itself. So area to look for is in eye disease. Who knows, maybe one day we'll be able to reverse age-related eye degeneration, eye diseases. Diabetes is one of active research and has been going on. You can see here that cell-based therapy is just but one arm of the different ways to treat diabetes. As you know, diabetes affects a huge amount of patients with it. People have been exploring gene therapy. Insulin, of course, is something that we've always been used to treat it. People have been transplanting insulin pancreas into the patient, and of course immune therapy, because diabetes is perceived to be an autoimmune disease as well. So what happens is that this is how it goes. This has actually just been published in August 2020 in today's newspaper, but stem cell treatment offers new hope for diabetes. But the clinical trials of these stem cell therapies are still not very good. There are many questions, there are many technical hurdles to be done about. And however, if you look at the trials, and just to summarize for the audiences, is that it still represents the most advanced approach to curing type 1 diabetes. The main thing is, how do we differentiate these cells? How do we localize the cells into it? How do you actually make these cells produce insulin? These are all various hurdles that have to be overcome, but it's definitely showing promise right now. Of course, heart is very important. A lot of patients suffer from heart failure. As you can imagine, heart attack is also very, very common. And you can see then just schematic, just to show you that how we are able to use cell-based therapy to help with the heart. Of course, you can see here, origin. You take the cells from various parts. You can take from embryonic stem cells, you can take from the bone marrow, you can take from the patient's muscles, and you transform them into hematopoietic stem cells, or you transform them, into stem cells. And then what you do is that you either put them in a matrix, and then you inject them into the heart itself. And hopefully these stem cells will go and localize into the heart itself, increase the ventricular function or the beating of the heart, and revascularize the heart, reviving the heart. Because what happens in heart attack basically is the heart muscle is being destroyed and is not able to do its work it's supposed to do. And this is what cell therapy promises to be able to achieve. So is there any trials going on? Yes, a lot of it, unfortunately, is in rats and pigs. We are not rats and we're definitely not pigs, but there have been some trials going on in humans already, and you can see that it seems to have some increase or some improvements in the patient's function of the heart using cell therapy. So this is an area that's also showing a lot of promise. However, I think in the heart, as in all the cell therapies right now, we're always worried about tumorigenicity, which is because these are all stem cells, they can always divide. You're always afraid that you'll keep dividing and dividing and dividing and form a cancer or tumor, which is something that you don't want. Of course, immunogenicity, because some of these cells are not yours or from donors, or your immune system may start to reject these cells. And of course, cardiac cells, they don't only need to beat, they need to beat in conjunction with the rest of the heart cells. You can imagine your heart cells, they have an electrical system that causes your heart to beat in a very controlled way. But because you injected new cells, these new cells may not coincide with the beating of the other heart and causing risk of heart rhythms as well, causing what we call arrhythmias. So these are still unsolved, and these are challenges that they still have. But it is interesting, it has been showing promise, and we look forward to new trials that can actually try to overcome these hurdles and one day be able to actually cure heart failure itself. And another one about cell therapy, how we use in gene therapy, is that stem cells can be vehicles after they have been genetically manipulated. So what do we mean? Gene therapy has been with us for many, many years. So if you look here, is that the current gene therapy, or the gene therapy that I used for years, is that we actually take a gene, we actually use a virus, and then what we do is that we use the gene to actually inject we put the gene in the virus, inject the virus into the human, and hopefully the virus will go and localize itself in a target organ. This is what gene therapy has been for the last 20 to 30 years. So currently, the current thinking is that we still take the gene, we put it in a virus, but the virus will infect a stem cell. And using these stem cells, we will put these stem cells with the infected virus and put the stem cells back into the human. And then hopefully this will generate the protein or the missing enzymes that the patient is lacking. So one illustration, or a proof of concept that has been done, is this in hemophilia. Being a hematologist, I'm excited about this because gene therapy has been trying for hemophilia for yonks. Hemophilia is a bleeding disorder in which a patient does not have enough of what we call clotting factor. So what happens in this is that this has just been published about a year ago. They take the urine from a patient with hemophilia, they take their cells, they induce it into a pluripotent stem cell, they infect it with a virus, the virus causes the cells to produce factor VIII, and then they put these cells back into the patient, into the mice, sorry, not the patient in this case. So this has been proof of concept, it seems to work, and this is something that people are working towards in the future. All right, so we're talking about all these cell therapies. Unfortunately, all the cell therapies that I have mentioned are not approved by FDA. CAR-T is the only one that's approved by FDA, and that's why I'm going to talk more about it as well. So I think all the Singaporean audience here are very familiar with Oscar. Oscar is a patient that came under NUH. He came from UK, and he was cured of leukemia using CAR-T therapy in Singapore. And he has now went back to UK, and he's very, very well. So what is CAR-T, and why is it so important, and why is it so useful in the treatment of cancer? So CAR-T uses our immune system. So T cells, our immune system, that plays a key role in our fight against the disease. They help the immune system respond to a disease and directly kills the cell. So chimeric, or if you remember chimera, which is Greek mythology, there is a lion head, a snake of a tail, which is exactly what it is, a mismatch. We use all these CARs, which are engineered receptors, to graft specificity into the T cell, because the T cell is not specific, it attacks every single thing. So what we do is that we so-called harness the power of the T cells by putting in a receptor to graft it so that it's able to actually attack and identify the tumor or the cancer that you're looking for. All right, so in a way, this is a chimera because this is something that we created in the lab. So this shows you what it is. You actually collect the patient's white blood cells because you want to use the harness the power of the patient's immune system. You isolate the T cells, which is the ones that we're looking for. You engineer it, just like we're trying to form a chimera. So we engineer it to make it recognize and make it more potent. We expand the cells, then finally we return the cells to the patient with the CAR T. So what happened is that we need to collect the cells first, then after that we will manufacture it and then finally put it back to the patient, and then it will do its work, go in and attack the cells that is being identified for target. So in a way, it is a very directed way of treatment. So you can see that this slide, CAR T has been around with us since 1989, and then it has moved on and improved upon generation after generation. And finally, in 2017, FDA approved the first CAR T therapy in it. And currently, more than 300 over CAR T cell trials are being registered. So you can see here is just genomics is the three therapies, three CAR Ts that are being approved on the market. They're mainly for patients with leukemia and lymphomas. This is just another way just to tell you about the trials, the Zuma, the Juliet, and Transcend. This one has just been approved by FDA in February this year, so this has just been approved as well. So you can see that things are moving along this as well. And there are new CAR Ts being reported. This is just in the latest December 2020 in the American Association of Hematology meeting, and you can see there are many more trials being on. And the thing to note about these trials is that the response to the patient in these trials is amazing. It's very high, and these patients who are heavily pre-treated with lymphomas and they're not responding to conventional treatment, you can see that their response rates is over 80%, which is very promising to these patients with very poor options left. You can see there are more trials going on about it. And of course, there's also the idea of using allogeneic trials, CAR Ts, which is called off the shelf from healthy donors. So you take the CAR Ts, you take the T cells from healthy donors, so you don't need to wait for the patient. So the beauty of this is that you can have decreased costs. You can have these products that are already manufactured, already done, ready to go to give the patient. However, there are challenges as well. You may have what we call graft-versus-host disease. The body may just reject the CAR Ts that come from these donors as well. So something to think about, but there have been trials, and trials have been already conducted for it, and it seems to be very promising as well. So all these CAR Ts so far have been directed against what we call hematological or blood cancers like lymphomas and leukemias. What about solid tumors? People have also been actively looking into it. They're trying to put, if you can see in this schematic, T cells versus the tumor cells as well. So it's the same thing, harnessing the power of the T cells to actually attach, identify, and destroy the tumor cells, using the immune system to destroy instead of using chemotherapy, which is very harmful to the body. This is another way of doing it. You still harvest the blood from the patient. You actually, in the lab, you actually make the chimera, or we call the T cells, to identify the tumor cells, and then you use the T cells to destroy these cancer cells itself. So in theory, it is very good. But actually, there's some obstacles in it because unlike liquid tumors or what we call blood cancers, it is difficult to identify a specific target for these solid tumors like lung cancer, breast cancer, and so on and so forth. And people have been trying to find it, okay? And even if you find a target, the environment around or we call the microenvironment around these cancer cells prevent the immune response from happening or successfully killing of these cells. but people have been trying. This was data that just put out, just published in just this month alone. You can see there's so many targets here about how they're trying to kill the cells. So they've been trying CAR Ts in tumors, in lung cancer, liver cancer, brain cancer, even skin cancers. And so many trials are trying to use this as well. But other than CAR T, people are also using another one, what we call TIL, or tumor invading lymphocytes. So what happens is that these lymphocytes are inside the tumor, they reside the tumor, they take these lymphocytes who are inside the tumor itself because they are potentially able to kill the tumor, expand it, and then reinfuse into the patient. So instead of using the conventional way, they are actually thinking of another way to go about killing off all these cells, all these tumor cells itself. So there are many advantages and disadvantages, but I think for the interest of time, I shall just skip through it. But they are different, just to let everyone know there are many ways of doing it. So it also another way of using the power of the immune system or to treat tumors itself. So I think finally, before we move on to the challenges, we must always talk about COVID-19 because it's been with us for a year. So has cell therapy been even used in this? Yes, cell therapy has been used in COVID-19, and Novartis has one that has been using it. They've been using mesenchymal stem cells because we think that mesenchymal stem cells can reduce the lung injury and inhibit the cell-mediated inflammatory response. So what happens is that the COVID-19 or the SARS-CoV virus infects the lungs, causing inflammatory response, ultimately causing the lungs to fail and causing the patients to die. And hopefully by using this mesenchymal stem cells, we can reduce the lung injury and allow patients to recover and survive the infection. That is one way. Singapore also, we've got ourselves involved and also say that it's a multi-center trial between KK, SGH, and NUH. We actually take the COVID-19 specific T cells. That means that patients who have recovered, these T cells are able to attack the SARS-CoV-2 virus. We harvest them and we expanded them, and hopefully we can use them in a trial to attack and cure patients who are suffering from COVID-19. So I've been talking about all these trials, all these things. What is the future and opportunities? At the end of the day, there must be commercial interest in it. So you can see in this slide, there's 1,000 over trials worldwide ongoing. This is data in 2020. You can see that there are new drugs or new cell therapy that's being approved. That's used for refractory myeloma, B-cell lymphomas. There's also one for burns. There's also another one for metachromic leukodystrophy, hereditary optic neuropathy. So these are new treatment that's coming onto the market. You can see there is also one that is actually getting a lot of investment, 15.9 billion raised, of which a lot of it is coming from public funding. So actually public funding has been the main driver of it, and of course private financing has also been increasing. So you can see public funding is 8.5 billion and 5.5 billion of it is in private financing itself. And these are all the pipelines that's coming down. You can see that in cancer, solid tumors, there's a lot of interest in cell-based immuno-oncology, 492 trials coming on, cell therapy, 202 itself. All right, and gene therapy, of course, it's always, the interest is always there. But you can see that there's a lot of trials and the interest is mainly in oncology. But of course, in regenerative medicine as well, it's in heart, eye diseases like which I mentioned before. And you can see that there are thousands over regenerative developers active worldwide in all the regions, and every single region is already there. So it's up and coming, and it's definitely expanding. Okay, so right now we can say there's a lot of excitement in the sphere, but what are the challenges involved? Well, there are a couple of challenges or many challenges that we need to overcome. Not only the basic science that we need to overcome, we also need to overcome the rest of the manufacturing, because cell therapy is manufacturing. We do manufacturing, and because of that, we need to consider what are the challenges that we have. So this is one of the programs of the MSK, which is Memorial Sloan Kettering in America. You can see there are many of these boxes. These are all the therapies that are required, all the clinical facilities that are required. This is NUH. So basically NUH itself, this is our cell therapy service. We have a stem cell therapy, and this is all the different divisions that are involved just to create a successful treatment for cell therapy. So it's basically like setting up a hospital service. So it's not like cell therapy can be done in a private clinic, because you need the support and a whole team of people behind you to do it. So I think that is the challenge to do it. It cannot be in a clinic. You check into a clinic, say, hello, I give you the cell therapy, bye-bye, and go off. It doesn't work this way. You need a whole team of people behind you. All right, and I think the main thing about this is that what I mentioned just now was that there is scientific discovery and research. This is what happens. All the heart therapy, or just now I'm talking about the heart cells, the eye, all these therapies. But there's another one is that how do commercialization? How do we convert it? How do we move it from the lab, or we call it from the lab to the bedside, or to the patient itself. And this is where it comes in. So you can see that this is the ecosystem of Singapore. And I use this slide is that you can see that there is always discovery, there's concept development, assessment, implementation, clinical delivery, and productization. And just to do a little bit of what we call advertisement for ACTRIS. ACTRIS is where it's here. We are hoping to bridge the gap, which is what usually happens, and the challenges is that between the scientist and of course to the patient. How do we make this scientific discovery valid, or able to make it into something that we can process, that we make it a product that is safe and able to be commercially viable to be given to the patient itself. And this is where the challenges comes in, because we are very good in basic science. The commercial companies are very good in commercialization and manufacturing, but how do we bridge between the two, the scientists and of course the commercial partners? So this is another slide just to tell you about it. Research, development, of course, the manufacturing, the supply chain, we must not forget about it. And finally, the clinical part, how do we get the cells and how do we deliver these cells back to the patient? So another way of it is automation, and I think that is the way forward. I think in Singapore, the government is also promoting automation, and this is what we do right now. A lot of it is very manual. In cell therapy, we are doing how we call semi-automated already, using like the Prodigy device, and then finally, hopefully, we have a fully enclosed and automated process. So this is just another way. Currently, right now, very manual, and then maybe next time we just need a completely automated system itself as fully integrated, and then this will make things a lot faster and a lot easier and more efficient, and that's the way forward. So is cell therapy, is it expensive? Yes. So if you look at the CAR T that I was talking about, the commercial CAR T that's being marketed costs in the range of 400 to 500,000. Is this able to be affordable to everybody? No. So this is the healthcare finance system in Singapore. There are many, we call MediSave, MediShield, MediLife, MediFund. Are we able to support CAR T? Well, it's expensive. Currently, no, it's still a very expensive therapy, but hopefully working with it and working with the government, we are able to find some middle ground in which we can make it affordable to all the patients and make it freely available. So it's something to overcome finances and the cost of CAR T therapy, and of course, any other cell therapy that comes along the way. And finally, there must be regulation. So all these comes into it. It's something very new. Everything needs to become needs to be regulated, and we are setting up a national regulatory framework to it. And this is good because it helps us to have a very stringent and clear standards of practice. It will allow for a robust quality management system to ensure that our products are safe and effective for it. And of course, it allows us to have global collaboration in stem cell therapy. So once again, these are all the challenges in the manufacturing, in the quality, in the regulation, logistics. Let's not forget about it, how to ship, when to ship, how to get it done to the patient itself. And finally, two more issues about it is harvesting of human material for other humans has ethical implications, like the use of embryonic stem cells. A lot of people are still arguing about the ethics about it. So this is something that we should still be looking into it and always be revisiting. And finally, like everything in the field of medicine, we lack skilled personnel, be it the laboratory technicians, the research technicians, the quality management, and people do not grow on trees. We always need to train them, and we are currently lacking a supply of them, and we hope that in the future, more and more people will be able to join us and be trained in the field of cell therapy. So finally, this is my last slide. Cell therapy has the potential to revolutionize medicine. I hope that I have managed to elucidate that. There are more and more approved CAR therapies in the pipeline. Explosion in new clinical trials. You can see there's a lot of increased funding and a lot of increased investment in it. However, challenges remain, but I'm sure that over time, if we work towards and work together, we will be able to overcome them and finally make cell therapy a reality in the future. Okay, with that, I thank you for your attention.
Okay, thank you, Dr. Yap. Now we'd like to open the time to the audience to pose your questions. I think we already have quite a number of questions. There are as many as 10. We'll hand the time to Dr. Yap to answer some of these questions. Dr.
Yeah.
Yap?
Do we need HLA matching for stem cell therapy? Yes and no. It depends on actually what you are actually transplanting in stem cell therapy. So as I said, stem cell therapy, if we're thinking about patients with, let's say, hematopoietic stem cells, yes, you need definitely you need HLA matching in these patients. Let's say for if it's heart, let's say if it's for the, let's say, knee joint, cartilage, and if it's autologous, you're taking it from the patient itself, then no, because it's the own patient cells, you don't really need HLA typing for that. But for others, yes, there's of course a risk of rejection if you do not HLA type. Okay, so as for this question about the strategy and roadmap that Singapore is taking with regards of cell therapies, yes, I think right now is that is the focus and the goal of ACTRIS itself. I'm sorry, this sounds like a bit of a self advertisement here, but I think the goal of ACTRIS that's been set up is to try and pull together the resources of all the various organizations out there, because we have a lot of very good researchers in ACTRIS. They're able to do all these basic research and all these, but the main thing is how do we able to bring all their research, and they're finding difficulties to find their research into a commercial firm or make it into a clinical reality. And I think that is why ACTRIS is specifically set up by the ministry itself to try and help these basic scientists navigate the road to a commercialization and of course to regulations itself. So I think this is the step forward in ACTRIS, and I hope that and also in the terms of research, now more and more research grants are being granted, and you need to have a partner, and ACTRIS hopes to partner with them to help bring all these cell therapies to reality. It's I know I didn't answer this question in full. It's a bit more complicated than that, but this is where the direction is going. And I think it's a direction moving forward. It's a good direction that we're moving forward to. Okay, so another question is, will a physician decide on the prescription of advanced cell therapy to treat cancer patients versus available treatment options or immunotherapy drugs? How? Well, it depends. I think right now, I'm a hematologist right now because immunotherapy is still very, very expensive. We still use the standard therapy right now, chemotherapy. But for oncologists, immunotherapy now is becoming first line for some of it. Let's say, for example, patients with stage 4 lung cancer and they have EGFR, EGFR called endothelial growth factor. So we have a specific endothelial growth factor inhibitor that we go for it. So actually, if you look at it, more and more, we may target, depending on the target that we find, we may be able to do that. But currently right now, for cancer patients, our first line is still the good old chemotherapy that we have right now. If that fails, then we'll move on to cell therapy if one is available. All right, so, oops, okay. For treatments such as organs such as brain and heart, how are cells transfused into the patient? That's a good question. For brain, you right now in the clinical trials and in animal trials, they infuse it because there's a thing called a blood-brain barrier. They infuse the cells directly into the brain. That is what they do. As for the heart, they actually put a scaffolding. They put and do a small operation and put the scaffolding onto the heart or inject directly into the heart itself. Yeah, not into the bloodstream, not yet. Yeah. So people are trying, and I think but the homing part is difficult, and it's something that scientists are trying to overcome itself. So what types of cell and gene therapies have been approved in Singapore to be used to treat diseases? There is currently no, not yet, we have no approved therapy at this point in time, but I'm sure it will come in the future. The current CAR T therapy that's given in Singapore is on compassionate ground. So these are not approved yet by HSA, but I think if I'm not wrong, then most probably the Novartis, the Chimera, will most probably be coming on to it, to coming to the market in Singapore in the very, very near future. Don't understand this question. Let me get back to you on that later. What is the process of CAR T for non-hematological malignancies and solid organs? Lester, I have to get back to you on this. I don't really understand the question as well. Maybe we can find. For Jasmine, how much does it cost for CAR T treatment? If the commercial product comes to Singapore, don't know in Singapore, but currently in US, it costs about $500,000. How important is the risk of autoimmune disease or diabetes after CAR T therapy? So far, right now, there's no reports about that, but I think it's a valid question. There will be more long-term reports, but the current trials that have been using Chimera, which is the one that's used by Novartis, no reports of it as yet, but we shall see in the future because these things may take time for it to come up. Okay, anything else? The overall response rate from CAR T trials has been observed in both RR and first-line treatment. The overall response rate for CAR T trials are mainly in patients with relapsed and refractory diseases, and we're looking at about 80 to 90%. They have not yet been used in first-line treatment for leukemias. Yeah. So another one by William, how to make T cells allogenic. How to make T cells allogenic? Don't understand that question. Okay. Oh, okay. You mean how do you make the T cells be able to be infused into other cells? How to make T cells allogenic? Let me get back to you on this. By Lo Wei Chin, as a physician, what is your views on the use of allogenic CAR T cells versus autologous to treat cancer patients? What are some examples of your consideration? I think it goes back to the same question just now of allogenic auto T cells. I think the challenge is that the patient must have an intact immune system. If you can imagine, if I give so much chemotherapy to the patient, sometimes the bone marrow actually just stops manufacturing itself. So it's not able to work. And you can't harvest an immune system or white blood cell from the patient if they're not even producing any white blood cells. So that is the challenge that sometimes we currently face. If you have an allogenic CAR T, the patient is healthy, you just take the CAR T from the patient itself and you're able to so-called maybe manufacture it and freeze it and put it on the shelf itself. So I think currently right now, allogenic CAR T is not available on the market. It's still in a clinical trial basis. So we shall have to see how things pan out. I think it's very, very hard for me as a physician right now to be able to advise or to look into it. I hope the technology works, but right now, without the trials being published, I think right now we can just say it's in a very, very experiment in a clinical trial phase, and I can't choose basically as a clinician right now because it's not even available on the market. Yeah. So what happens to CAR T in the body in the long run? Well, in the long run, actually, hopefully, because it's autologous, it stays in the body, still forms the surveillance, and actually, it actually, theoretically speaking, should stay permanently in your body it itself. But we are looking into it. We need to monitor and to see the persistence of the CAR T in the body. So I think it's a good question. How long will it stay? Most probably forever, but we will continue to monitor. I think the patients on the trials are still being monitored, and we shall see how persistent the CAR T will be. There is a new first trial in patient using engineered cardiac tissues. If the expertise and knowledge know-how in Singapore, how is it required to bring this to apply as a potential study here too? Let me get back to you on this, about this as well. There are some questions which I think it may be easier if I can email you directly, so that it will be better that we can talk about this. Why are cancer patients in Singapore usually filtered towards filtered towards small molecules, chemotherapy, and not immune therapies? How should patients go about getting immune therapies if their primary cancer doctor start them on chemotherapy, but patients are not responding well? Okay, so I am not an oncologist. I know what you're trying to say. I think I better not comment on what my oncology colleagues are doing because I am a pure hematologist. But right now I think if you look at it, it is the establishment of effectiveness of treatment. Immuno or cell therapy for cancer, as you know, is for solid tumors are very, very preliminary. They're in the phase 1, phase 2 trials. And usually because of that, as the trial is not recognized, not recognized, they are not approved as oncologists or even as hematologists, we do not offer trials that are, treatment that is not approved yet in the market. So that is why we are not using that yet. Yeah, once, of course, cell therapy becomes approved and standard of care, they will definitely be offered to patients. Yeah. Am I missing any more questions? Where are... I'm sorry, there are a lot of questions. I may be missing some of them. Let me see. What is the current established national regulatory standards of practice? For cell therapy, we are still formulating, so it's not out yet. It most probably will be available in the next 1 to 2 years, hopefully. So then there will be at least a regulation standard of practice for using of cell therapy. Are you able to share some example of cell therapy manufacturing work that ACTRIS is working on? Are these mainly collaborators? Well, we're working, I think the short answer to that is that, broad answer to that, we're working with everybody. We're working with biotechs, we're working with scientists, we're working with basic scientists to bring their projects forward. We welcome any collaboration with anybody. So you can always come forward with us and we see how we can discuss with it. So so everybody, biotechs, A-star scientists, anybody who wishes to bring cell therapy into the market, and we are very, very happy, of course, to discuss with you, talk with you, and if of course to collaborate with you to bring your project forward. Yeah. There's one question here: incidence of lung embolism with IV infusion. I assume that you're thinking if you infuse cells. Not very sure how to answer that question. Yeah. Okay. I apologize. There are really quite a lot of questions I can't really follow. Okay, I think there's one here. CAR Ts have been used to target and destroy tumor cells, but have there been instances where CAR T cells are targeted to heal disease cells? No, I don't think it's possible. Given my knowledge of CAR T, of course, I acknowledge my CAR T knowledge is not the best, but CAR T itself, by using T cells are actually what we call our immune cells that actually destroy cells. So actually they have no properties of healing. So it's very unlikely that we're able to use CAR Ts to heal cells in that aspect. There's one about mention for skilled manpower in cell therapy. Can ACTRIS do to help in this particular when our universities in Singapore do not have formal training or framework? Yes, I think that's a good question by Ian. ACTRIS is working with the universities in Singapore to offer professional certs in the process. And of course, these lecture series also helps too. But yes, we are working towards we are definitely working towards that to help patients. Why am I talking about patients? To help people who are interested in cell therapy to upskill yourself in that. So keep your eyes open. I hopefully within the next 1 year we're able to come up with something to offer to anybody who's interested in cell therapy and to bring cell therapy forward on a whole and upskill everybody.
Okay, I think time is up. I think there are a lot of questions that are coming in. Thank you for all your questions. I think what we'll do is some of those questions that Dr. Yap is not able to answer, we'll try and see if we can address it later. But for those whose answers has already been answered, thank you for your questions in the first place. I hope all of you had enjoyed the webinar, and we will be sharing the recording. Time to come, we'll put it onto our website, and when it's ready, we'll send a message to all of you and let you know. Okay, thank you everyone. I hope you enjoy yourself, and thank you, Dr. Yap.
Thank you.
Have a pleasant afternoon. Bye-bye.